So if a guy walks into a clinic today, complaining of sexual dysfunction, modern medicine is just incredibly efficient.
Oh, absolutely. It's a very streamlined process.
Right. They basically hand him a targeted molecular solution, usually a little blue pill, and they do it in a matter of minutes. The whole assumption is just really straightforward.
They assume it's a mechanical issue.
Exactly. It's an issue with blood flow, and we have the tools to fix the plumbing.
Yeah.
But historically, if a woman walked into that exact same clinic with the exact same complaints, like localized numbness, lack of blood flow, or pain, the medical response has been wildly different.
Wildly different.
She was often, handed a lubricant, maybe told she was probably just stressed out from work, and perhaps recommended to see a therapist.
It is a really stark diagnostic double standard. For decades, the medical establishment treated male arousal as this structural vascular event requiring pharmacology.
Right.
But they treated female sexual dysfunction, or FSD, as a purely emotional or diffuse psychological issue that just required a bit more patience.
Just relax, right?
Exactly. And the clinical consequences of that divide have been profound. It left an entire demographic of patients without rigorous FDA-approved physiological treatments. They were basically stranded in diagnostic muddy waters.
Okay, let's unpack this. Because today, the science is actively fighting back against that narrative. We are setting out on a mission to explore the absolute cutting edge of female sexual wellness and regenerative medicine.
It's a fascinating shift.
It really is. And the core focus of our deep dive today is a massive question. Can emerging regenerative treatments, specifically highly engineered intimate exosome therapy, actually enhance localized clitoral neurovascular engorgement and arousal latency, especially for premenopausal women?
And to really answer that, we have to look at the underlying biology of female arousal. If we connect this to the bigger picture, female sexual arousal is just as deeply and fundamentally vascular as male arousal.
Yeah, the biology is actually very similar.
It is. The clitoral and vaginal engorgement processes depend heavily on nitric oxide release and measurable blood flow. But the architecture of that vascular network is much subtler.
Right.
The timeline for engorgement is a lot more variable, and crucially, it is inextricably linked to a complex psychological ecosystem.
Which is what makes it so interesting. And we've got a fascinating stack of sources guiding us today. We're looking at everything from double-blind, randomized clinical trials, systematic reviews on cell-based therapies, to the actual treatment protocols being deployed right now in high-end aesthetic clinics.
There is a lot of new data.
So much data.
Yeah.
But before we can even begin to tackle the futuristic promises of, cellular regeneration and exosomes, we have to look at how medicine is currently trying to address that immediate mechanical need for blood flow.
Right, because you have to start with the baseline.
Exactly. You can't talk about rebuilding the roads until you look at how we are currently managing the traffic. So let's look at the immediate fixes.
Which brings us to vasodilators. For the longest time, the only things offered to women were standard lubricants, which, they do absolutely nothing to enhance clitoral blood flow.
They just mask the friction.
Precisely. They do nothing to alleviate decreased sensation. But researchers recently decided to see what happens when you bypass the systemic pill entirely and focus just on the local tissue.
And this was a major breakthrough documented in the clinical literature, right? A 2024 multi-center pilot trial of a topical sildenafil 3.6% cream.
Yes. Essentially, this is Viagra, but formulated to be absorbed directly into the local genital tissue of women suffering from female sexual arousal disorder.
I want to pause on that because it's important. They had actually tried oral Viagra for women in the past, but the results were notoriously frustrating.
There were. The systemic side effects were too high.
Right, because when you take a pill, it has to pass through your digestive system into your bloodstream and it affects your whole body.
Yeah.
Women were getting severe headaches, facial flushing, and blood pressure drops.
But they weren't necessarily getting the localized engorgement they wanted.
Exactly. The side effects completely outweighed the benefits. So this sildenafil cream circumvents that whole body exposure.
Sildenafil works by inhibiting a specific enzyme called PDE5.
Wait, I always hear about PDE5 inhibitors in those pharmaceutical commercials. But what is that enzyme actually doing in the body that we need to inhibit it?
Think of PDE5 as a biological off switch for blood vessels. In a normal state, your body releases nitric oxide to relax the blood vessels and allow blood to rush in.
Okay.
But PDE5 comes along to break down those signaling molecules. It essentially causes the blood vessels to constrict again. It actively limits the blood flow.
Ah, So by applying a sildenafil cream directly to the clitoris and labia,
Yeah.
you are temporarily blocking that off switch in that specific area.
Exactly. It allows the nitric oxide to do its job unopposed. That enhances vasodilation, relaxes the vessels, and allows a rush of oxygenated blood.
And the 2024 trial reported statistically significant improvements in subjective arousal and physical genital engorgement, all with minimal whole-body side effects.
It's a huge step forward for targeted treatment.
And what's interesting is that the sources show researchers aren't just relying on nitric oxide pathways. They are exploring completely different biological mechanisms.
Yes, there's another fascinating topical approach in the literature.
Right, using an active ingredient called visnidine. This is extracted from a plant called Amivisnaga. And instead of blocking the PDE5 enzyme, visnidine acts as an L-type calcium channel blocker.
The mechanism there is completely different, but it's equally crucial. You see, calcium ions are the fundamental trigger for muscle contraction in the human body.
Okay.
When calcium enters the smooth muscle cells that wrap around the tiny microvessels in the vulvar region, those muscles squeeze,
Yeah.
and that constricts the blood vessels.
So visnidine is essentially a bouncer at the door of the muscle cell, just refusing to let the calcium inside.
That is a highly accurate way to visualize it.
Okay.
Because the calcium can't enter, those smooth muscles are basically forced to relax.
Wow.
And when it's applied as a spray or an emulgent about 10 to 15 minutes before sexual stimulation, the smooth muscles wrapping that local vascular network just loosen up.
And the clinical studies show this significantly improves the female sexual function index, the FSFI.
It does.
Yeah.
Particularly pushing up the scores for natural lubrication and the ease of reaching orgasm, simply by increasing regional blood flow and lowering the sensory threshold.
Okay, so we have creams and sprays that chemically coax the blood vessels to open. But the sources also detail an approach that sounds, completely counterintuitive on the surface.
You're talking about the clitoxin procedure.
Yes, the clitoxin procedure. This involves injecting botulinum toxin, literally Botox, directly into the clitoral area. I have to admit, when I read this, I was totally baffled.
It throws a lot of people off.
Botox is a paralytic. We use it to freeze forehead wrinkles. How on earth does paralyzing a muscle facilitate arousal?
It seems like a massive paradox, but what's fascinating here is the pelvic anatomy. FSD isn't always just a lack of chemical signaling. Sometimes it's a physical, structural bottleneck. The pudendal artery and the nerve branches, which supply that entire clitoral network, they weave through a very complex web of pelvic floor muscles.
Okay, I'm picturing it.
If a woman has hypertonic pelvic floor dysfunction, meaning those muscles are constantly tense, spasming, or clenched, those muscles literally act like a tourniquet. They strangle the blood supply.
Ah, I see. So the clitoxin isn't targeting the erectile tissue itself, it's targeting the surrounding muscle bed.
Exactly. Clitoxin temporarily blocks the nerve signals that tell those surrounding muscles to contract. By forcing the muscular structure to finally relax, you remove the physical constriction.
The tourniquet is released.
The tourniquet is released,
Okay.
and that leads to dramatically increased blood flow and heightened nerve sensitivity. And unlike a 15-minute cream, the effects of that muscular relaxation can last for several months.
So to put this in perspective for the listener, using a vasodilator cream like sildenafil or visnidine is basically like opening the floodgates to force the water through the pipes.
That's a good way to look at it.
But using a neurotoxin like clitoxin is more like clearing the roadblocks. You're relaxing the tense muscles so the natural traffic can flow freely again.
Both strategies ultimately achieve the same primary goal, which is getting more oxygenated, nutrient-rich blood into the clitoral neurovascular network.
Which naturally leads me to a major point of pushback.
Let's hear it.
If we have creams that work in 15 minutes and injections that clear the roadblocks for months at a time, why is regenerative medicine even entering the chat? Like, why go any further if these tools are already forcing blood flow into the tissue so effectively?
Because forcing blood through an aging or damaged pipe doesn't fix the pipe itself.
Oh, right.
These are temporary facilitators. They remove vascular barriers for a set period, but they do absolutely nothing to repair degraded tissue.
That makes sense.
If a woman is experiencing thinning mucosa, cellular aging, or microscopic tissue tearing from childbirth, or the massive estrogen drops of menopause, pushing more blood into that fragile tissue might not even be comfortable.
It might actually hurt.
It could. Vasodilators manage the symptom. They do not rebuild the foundational infrastructure.
And that realization, that we really need to transition from just managing symptoms to actually healing the tissue is what drove the medical field toward autologous therapies.
Yes, the focus shifted to long-term healing.
They started looking for ways to heal the tissue long-term using the patient's own body. And you might have seen this advertised in aesthetic clinics as the O shot, which utilizes platelet-rich plasma, or PRP.
PRP is an autologous biological product, which simply means it is derived entirely from your own body.
Right. And the clinical protocol is relatively straightforward, isn't it?
It is. A practitioner draws a small amount of the patient's blood, much like a standard physical exam. That blood is placed into a centrifuge, which spins at high speeds to separate the red blood cells from the plasma.
And what you are left with is this golden serum that is densely packed with platelets and specific growth factors.
Exactly.
Now, the sources mention a lot of acronyms here, specifically VEGF and PDGF. Let's decode those. What are these growth factors actually doing once they are isolated?
So VEGF stands for vascular endothelial growth factor, and PDGF is platelet-derived growth factor.
Okay.
If you think of your vulvovaginal tissue as a biological construction site that has fallen into disrepair, these growth factors are the site managers.
I love that.
When this concentrated plasma is injected into the anterior vaginal wall and the clitoral area, those site managers start yelling at the local cells to get back to work.
They're barking orders.
Pretty much. They stimulate collagen synthesis, and most importantly, they trigger neovascularization, which is the literal creation of brand new blood vessels from pre-existing ones.
Now, I need to play devil's advocate here. In almost every other area of modern wellness, whether it's skincare or nutrition, natural and autologous is considered the absolute gold standard because your body won't reject it.
That's the common perception, yes.
Right, and aesthetic clinics advertise PRP as this perfectly natural, non-hormonal way to permanently increase vaginal tightness, improve lubrication, and guarantee stronger orgasms. So why are researchers still looking for alternatives?
It's a very fair assumption that natural is always better. But here is where the logic breaks down in regenerative medicine, and where the clinical reality in our sources reveals a major catch.
The data doesn't quite match the marketing.
No, it doesn't. While aesthetic clinics project uniform, miraculous benefits, the systematic reviews of the actual scientific literature show highly fragmented, incredibly mixed evidence.
The 2025 double-blind randomized controlled trial is a perfect example of this. Researchers took 60 postmenopausal women and compared PRP injections against a simple saline placebo injection.
And when they tracked the outcomes over 4 months, the results completely weakened the narrative of a guaranteed broad-spectrum sexual rejuvenation.
What did they find?
The women who received the PRP did show a clear, statistically significant improvement in their overall female sexual function index scores. But when you look closely at the specific domains of that index, the significant improvements were isolated.
They were only isolated to lubrication, overall satisfaction, and a reduction in pain. Right. The data explicitly showed that the PRP did not significantly improve the scores for actual sexual desire, arousal, or orgasm.
Furthermore, systematic reviews point out a massive lack of standardization across these PRP clinics.
Oh, like how they actually prepare it?
Yes. One doctor might draw and inject 2 milliliters of plasma, another might inject 10 milliliters. They use completely different centrifuge spin cycles, which can actually damage the platelets.
Wow.
They inject into slightly different anatomical sites. It is basically the Wild West of clinical protocols.
So if you're listening to this and trying to navigate your own menopausal symptoms, what does this actually mean for you? It seems like PRP is essentially a healing soup that relies entirely on the variable quality of your own aging blood.
That's the crux of it.
If a 60-year-old woman is seeking treatment for menopausal tissue degradation, her blood plasma is also 60 years old. It might simply not have the same regenerative horsepower as a 25-year-old's plasma, which perfectly explains why the clinical literature is so wildly inconsistent.
That is the exact clinical limitation. While PRP was a logical first step toward true regenerative healing, its inherent unpredictability paved the way for a much more precise demand.
We needed something better.
The field realized it needed a highly engineered, standardized solution that didn't rely on the variable quality of the patient's own blood. We needed the signaling power of the growth factors, but purified and amplified.
Which brings us to the core mission of today's deep dive. The next-gen regenerative frontier, exosome therapy.
This is where it gets really futuristic.
It really does. If PRP is limited by your own biology, exosomes offer a mass-produced, highly targeted alternative. But we need to be very clear here because the marketing around this gets confusing. Exosomes are not stem cells, right?
No, they are not cells at all. They have no nucleus, no DNA of their own that can replicate.
Okay.
Think of exosomes as microscopic extracellular vesicles. If a stem cell is a computer, the exosome is the biological USB flash drive it ejects.
Oh, that's a great way to think about it.
They're tiny nanoparticle envelopes packed with highly specific proteins, peptides, growth factors, and genetic signaling molecules like microRNA.
So they don't actually build the tissue themselves. They plug into your aging, degraded cells and upload a new set of instructions.
Exactly. They act as master communicators. They deliver a payload of regenerative instructions to the recipient cells.
And the sources highlight some highly specific branded protocols entering the market, like the Isoplus Intimacare IRLV solution.
Yes, that's a major one.
This isn't just a random blood spin in a back office. The product claims to use 5 billion high-purity exosomes derived specifically from rose stem cells packaged alongside high molecular hyaluronic acid and peptides.
It's a very complex formula.
But as objective analysts, we have to ask, is this 5 billion exosome claim just slick aesthetic clinic marketing? Or does the clinical data actually back up this level of cellular manipulation for arousal? Like, how does this impact clitoral neurovascular engorgement?
The biological mechanism is undeniably robust. Whether they are derived from specific botanical stem cells like the rose or highly purified human mesenchymal stem cells in a lab, exosomes do something remarkable when introduced to vulvovaginal tissue.
What happens?
They upload instructions that stimulate the local fibroblasts, which are the cells responsible for structural integrity, to rapidly synthesize fresh collagen and elastin.
And what about the blood flow, the arousal latency?
This is where it completely surpasses PRP. Exosomes have been shown to induce true angiogenesis.
So, new blood vessels.
Yes, they don't just dilate existing vessels, they instruct the tissue to construct complex new microvascular networks. Furthermore, studies on animal models show that these exosomes actively decrease oxidative stress in the corpus cavernosum.
Which is the internal erectile tissue of the clitoris.
Exactly. They are cleaning up cellular damage while laying down brand new, highly responsive vascular plumbing.
And we see the undeniable proof of this tissue repair in severe medical conditions. The sources note that exosomes have emerged as a promising treatment for vulvar lichen sclerosis.
That is a very painful condition.
Right, it's a chronic condition that causes severe thinning, itching, and tearing of the genital tissue. Patients who completely fail to respond to traditional steroid creams are finding relief because the exosomes are actually repairing the tissue architecture and restoring the natural protective barrier.
The localized physical tissue healing is phenomenally well documented. But, and this is a massive but, when we map this to actual sexual function,
Right.
there's a reality check in our sources. We looked at a systematic review and meta-analysis of cell-based therapies specifically aimed at treating female sexual dysfunction. The researchers pooled individual patient data from 29 women across 3 different clinical trials utilizing these types of cellular messengers.
And they measured success using the Sexual Quality of Life Female Questionnaire, the SEQUEL-LF. This is where patients self-report on their actual lived experience of intimacy.
And the results of that meta-analysis. Across those trials, despite the proven biological repair occurring at a cellular level, the SQUIV-UF scores were not significantly improved overall.
Wait, I need to wrap my head around this.
It's surprising, isn't it?
Very. The exosomes are definitively reducing inflammation. They are definitively building brand new blood vessels and restoring the elasticity of the tissue. How does all of that biological repair not automatically translate into a better sex life for these women?
This raises an important question, and it represents the ultimate crux of female sexual medicine. Exosomes, PRP, and stem cell therapies are incredible at building the physiological capacity for engorgement.
They fix the hardware.
They ensure the hardware is healthy, elastic, and capable of responding, but they do not operate in a biological vacuum. You have built a perfectly functioning engine with brand new spark plugs, but you still need the driver to turn the key.
I love that analogy. An arousal cream like sildenafil acts in 15 minutes because it's a blunt, localized chemical reaction.
Right.
But exosomes are playing a months-long game of replacing the entire plumbing system. But just because the pipes are brand new, it doesn't mean the water is going to flow if no one ever turns on the faucet.
Exactly. You still need the psychological triggers, the mental presence, the desire, and the relational context to ignite the neurovascular system.
Which brings us to the final and perhaps most vital piece of the puzzle, the holistic ecosystem of arousal.
Hmm.
Because whether you are spraying Visnidine 10 minutes before intimacy or undergoing a 3-month highly engineered exosome protocol, the physical body is only half the equation.
It is.
Female sexual dysfunction is the exact intersection where biology and psychology collide.
If we look back at that 2024 topical sildenafil study published in the Shanghai Archives of Psychiatry, there is a beautiful, revealing finding about this mind-body connection.
Oh, the body image finding.
Yes. The researchers noted that the most substantial gains in overall body image confidence were actually seen in the women who started the trial with the highest, most severe levels of sexual distress.
Yes. This study explicitly states that FSD isn't just about a lack of blood flow. It is where impaired genital responsiveness collides with internalized shame, anxiety, and the fear of touch.
It's a huge psychological burden.
It is. When a woman's body stops responding reliably, she often internalizes it as a failure of her own femininity. But when they used the sildenafil cream and the physical body suddenly responded reliably and predictably, it removed that internalized shame.
It broke the cycle.
The women reported significantly less self-consciousness during intimacy and a much greater initiation of sex.
It perfectly illustrates a neurovascular emotional feedback loop. The medication itself didn't artificially cause the psychological desire,
No.
but by removing the physical vascular barrier, it cleared the path for arousal to occur without the heavy burden of performance anxiety. When physical readiness improves, psychological readiness has a safe space to follow.
Here's where it gets really interesting to me. When you synthesize all these sources, from the immediate vasodilators to the exosome therapies, we are finally witnessing a medical culture that is refusing to divide the genital from the psychological.
It's a much more integrated approach now.
These regenerative treatments aren't magic cures that ignite desire out of nowhere. They are biological facilitators. They create a safe biological space, a reliable physical foundation where sensation and mental presence can finally meet.
And that is exactly why the most cutting-edge aesthetic clinics are moving rapidly toward combination therapies. They are acknowledging that no single mechanism works alone.
What does that look like in practice?
In our sources, we see clinics routinely stacking treatments. They are pairing PRP injections with V-Care carboxytherapy, which pumps medical-grade CR2 into the tissue to force oxygenated blood flow during the healing process.
Wow.
Or they are combining exosomes with Femilift radiofrequency lasers to really compound the collagen regeneration.
Even the Menopause Society guidelines reflect this ecosystem approach now. For postmenopausal women, they suggest combining targeted arousal creams with daily topical estrogen.
That's a very common protocol.
The estrogen works slowly, over months, to repair the tissue integrity and thickness, while the arousal cream provides the immediate blood flow necessary for an encounter that weekend. It is a targeted, dual strategy that treats the whole patient.
It is about finally honoring the complex physiological reality of the female genital response. We are learning to treat it with the exact same clinical rigor, funding, and pharmaceutical precision that we have historically applied to male sexual health.
While recognizing that female arousal requires a holistic context to truly thrive.
Exactly.
So what does this all mean for you, the listener? To summarize our journey today, we started with the immediate chemical interventions, vasodilators like sildenafil and Visnidine that chemically coax blood vessels open.
And the paradoxical muscle relaxation of Botox to remove physical roadblocks.
Right. We then explored the autologous, yet wildly unpredictable healing potential of using your own blood in PRP. And finally, we analyzed the microscopic, highly engineered USB drives of exosome therapy, which instruct your body to build entirely new vascular infrastructure.
It's incredible how far the science has come.
It really is. The overarching takeaway is this. Your sexual health is a legitimate, measurable, biological, medical concern. It deserves nuanced, evidence-based care, not just a dismissive suggestion to reduce stress and drink a glass of wine.
And I'll leave you with one final thought to ponder as we wrap up this deep dive. If regenerative medicine like these highly purified exosome therapies can truly and effectively restore vulvovaginal tissue to a premenopausal state of vascularity, elasticity, and responsiveness, how is this going to inevitably shift our societal expectations of aging and intimacy?
It's a big question.
If the biological clock on sexual function can effectively be paused or even rewound, will regenerative intimacy maintenance eventually become as routine, mundane, and normalized as going in for a 6-month dental checkup?
That is a wildly fascinating question. The diagnostic X-ray machine might still be a little murky when it comes to measuring the nuances of human desire, but the scientific tools to rebuild the machine itself are getting sharper every single day. Thank you for joining us on this deep dive into the sources. Stay insanely curious, and we'll catch you next time.